So the next question is about an entity that people call complex or progressive sarcoidosis. And I think we have to remove the complexity from complex. So the core question, as I've outlined, is whether an illness is dangerous, and if not, whether people feel hugely unwell with it. And I think what is meant by complex sarcoidosis is probably, and someone has to explain to me exactly what this means, but I've always felt that it meant that you've got danger there. It might be danger that is a bit more difficult to define, or else you've got sarcoidosis that is disabling you even though it isn't dangerous because of the symptoms, or you've got a mix of the two. And I would say the only way to come to terms with that is to actually be very simple. So you define danger, you define loss of quality of life, you accept in some people as a complex mixture, and you have to work it out person by person. Now, I certainly don't think there's something we can call complex sarcoidosis that gives us a standard management for the thing called complex sarcoidosis. Look, you've got people who've got a difficult disease. You've got people who've got a straightforward illness with no symptoms that's going to go away. There are going to be shades in between that. And my problem with complex sarcoidosis is it almost serves as a barrier to understanding when we should be talking about what the risks are and what we should do about them, preferably not using medical jargon, so you've got a partnership in management. And so I would say there's a group of people who have simply more difficult disease for them to deal with and a doctor to deal with. But if you keep your eye on the ball as a doctor, that is to say you are constantly asking yourself, is this dangerous? And how do we work out the impact on your life? And often the patient will be able to tell you that in spades. Then I think we avoid that label. So we go back to first principles at all times, I think. Progressive sarcoidosis was the second part of the question, and really all you're saying there is that the disease is getting worse with time. And often it will do that for a period, and then the heat will go out of it. Because in sarcoidosis, I've talked about it as a loss of immune balance, but generally with immune imbalances, more often than not with time, the immune system forgets and the heat will go out of an illness. Not always, but quite often. So if sarcoid is progressing, it means with a bit more time, it's starting to worsen, and you're going to have to make a judgment there whether this is minor worsening, which is likely to get better with time, or whether this is something more serious. What I will say is that when you're assessing danger from sarcoidosis, there are two bits to this. There's the assessment at the start, when you're looking at how severe it is to begin with, and then there's factoring in how it's changing with time. So if you have a sarcoid illness that you think might be dangerous and you're not sure, then it's critical you work out if there's ongoing worsening, which for some reason we call progression. That is a bad word rather than a good word. Progression is bad. So you're using it to judge risk, and you're talking again to patients about whether the symptoms have worsened, and they now feel in a way they didn't before, that perhaps they should try something for quality of life. But never medical jargon. You've got to stay clear. I mean, we've just had a conversation where I've hardly used any medical jargon at all. And as long as you avoid that, you'll find yourself on the same wavelength, and there will be a logic. Yes, so the next question, and many patients are very anxious to address this, is the fact that sarcoidosis can affect multiple parts of the body. Now this can be lymph node enlargement or minor skin involvement and not major organ involvement. But sometimes there is more than one major organ involved. And there are a number of points to make about that. Firstly, it is true to say that if you have more than one major organ involved, it is likely that you will be in a higher risk group. And so this serves as a flag to be especially cautious. And for example, if you have severe lung involvement, you've got to be especially alert to what may seem to be minor cardiac involvement, because your ability to see the cardiac involvement will be masked by involvement of the lungs. You get a lot of symptoms you just say are lung disease, for example. So you have to be more careful in looking at danger in that setting. Now, having said that, it's very important to say early on that generally the pattern of sarcoid is true to an individual. Now, what I mean by that is that if you're a patient who goes to the internet, you might get the impression that sarcoid marches around the body, and you might find the unlucky people who always get reported and put on the internet that have the worst disease in each organ, and quite often you will have the impression that you will have all of these problems in time. And almost always that's not true. Now, there are occasional exceptions which are rare, where the pattern of sarcoid can change in the long term, but for most people, the pattern tends to be true to the individual. So you're getting a feel there, and then some of the organ involvements are trivial. So liver function tests, for example, will be done, and it is terribly common to get minor inflammation in the liver that never actually causes a problem and settles with time. If you had, although the idea is gruesome, a policy of biopsying the liver of every patient with sarcoidosis, you might conclude that 70% of patients had liver sarcoidosis because you can find trivial sarcoid abnormalities. In reality, it's less than 1% that have true, important liver sarcoidosis. So you will find a bit of inflammation here and there. But in general, as I say, the pattern of what is more dangerous or more troublesome tends to be true to the individual. And so people should not be tyrannized by reading the internet and seeing the worst scenarios from doing that. I think that was all I had thought of saying. I have this horrid feeling there's one more thing in the back of my mind that I've lost, but be that as it may, is there anything else you'd like to ask about that?
Well, that's a good answer. The only thing maybe is just to clarify about whether or not sarcoidosis does spread between organs.
I don't think we see spread in the way we think of a cancer spreading. So in a cancer, you have a cell that travels from the site to other sites in the body. I don't think anyone's ever tracked sarcoidosis in that sort of way. Instead, I think you're talking about an immune imbalance, and the immune system itself operates in many different parts of the body. And then I suspect the nature of the trigger may determine the shape of sarcoid itself. So you've got an immune imbalance, which is part of it, but you've got something coming along, as we discussed, that sets the process off, and that something and the nature in which it does it may turn out to be important in determining whether sarcoid is confined to the lungs. But the immune system is everywhere in our bodily function, and that is why many patients have what are called systemic symptoms, which are not about involvement of one particular organ. They may have fatigue, they may have sweats, they may have malaise, loss of appetite, they just feel unwell, and I could make a list. And I don't think this is a matter of sarcoid cells spreading around the body. I think this is more that you've got a fundamental loss of balance of your immune system, which will have potential impacts all over the body, but will then follow a particular pattern that tends to be true to the individual. So not a cancer model, not spread from organ to organ. And I think it's important people do understand that sarcoidosis is certainly not a cancer. I don't think they are. I think you're still making the judgment every time is the danger. Now, you have to go organ to organ, and you also have to be aware of the causes of death due to sarcoidosis. Now, up to 2/3 of deaths are due to lung involvement. That might be in the substance of the lung, what we call pulmonary fibrosis, which is a fancy way of saying lung scarring. Fibrosis is scarring, pulmonary is lung. And then you might have a problem in the blood vessels in the lung. And some listeners will have heard of pulmonary hypertension, high pressure in the blood vessels of the lungs, which when severe can be fatal. And that is sometimes caused directly by lung damage, but in sarcoid it can exist, while the rest of the lungs are relatively mildly involved. So you're talking about 2/3 of the deaths being down to that. And so you're focusing on that first of all. When you assess somebody with multi-organ involvement, you're saying, we have certain lung function tests and we'll take aboard your symptoms and the look on imaging, and we'll put them together. Putting them together is more accurate than taking each thing in isolation, and you want an expert group to be able, the term is multidisciplinary, and what that means is that each thing you're looking at should be a discipline. You should be looking at how the disease looks on imaging. You should be hearing how the disease feels in the lungs to patients, and you should be examining the strength of the lungs with lung function tests. And from that, you will get a sense of risk. And we're getting better and better than that, and I think there are studies underway which are advanced, which will give more and more guidance. So that's 2/3 of the danger related to both single organ and multi-organ sarcoid. Then up to 25% from the heart. The heart is the tricky question because of all the organ involvements, it can be the heart that is most hidden. You know, liver disease you'll get from the blood tests. The rare severe kidney involvement you'll get from the blood tests. The lung involvement you'll get talking to the patient in a standardized way, doing the routine screening tests that are recommended. The central nervous system will generally be obvious. There are occasional exceptions, you've got to say that, but will generally be obvious from the way in which it affects the patient. If you have a Bell's palsy, there's no doubt what you've got. So in other words, you get some nerve weakness in the face, for example. I mean, that's obvious. So when you're working out risk, you've got a fairly clear lead whether you've got a single organ or multiple organ involvement in all those areas. And I think where we have to be especially careful is subtle cardiac inflammation, which may gather momentum over time. And we have to work out, especially when there's lung involvement, as I said before, that can mask what is happening in the heart. You describe a bit of breathlessness, it will be mostly correctly put down to the lungs, but not always. But if there is lung involvement, that's very tricky. So I think the thing we have to work out for multi-organ sarcoid, the pressing question is, what should we be doing to screen for cardiac involvement? And if there's any risk of our vision being blurred by the impact of the lung disease, we absolutely should be going a step further to exclude potentially major and dangerous cardiac involvement. So it's not enough to do an ECG, and we have to accept that symptoms can be difficult when you've got lung involvement. We shouldn't be putting down palpitation to benign rhythm disturbance. It may be common in that age group in healthy individuals, but we need to go the extra step in that setting and identify whether this is actually due to cardiac inflammation. Echocardiogram has been used around the world as a screening test, but I must say, based on more recent information, if you think there's a real risk of cardiac disease, you really do have to go to an MRI scan or a PET scan. And this is an area which is increasing exponentially. Now, we here at the Brompton have set up the first UK multidisciplinary meeting in cardiac sarcoidosis. 10 years ago, we had 10 referrals a year, and the referrals have doubled in each of the last 5 years, and we were up at 170 this year at this point. And we realize that there's a hidden epidemic around the place of cardiac sarcoidosis, which until now has not been detectable using advanced imaging. And now that we've got these advanced tools, I actually wonder how we got by on cardiac sarcoidosis in the past. I think we were flying by the seat of our pants. But in this meeting, and I really want to highlight this, when you talk about multi-organ sarcoidosis, that it's cardiac disease we need to focus on as well as the lungs. You have in a multidisciplinary meeting 6 skills in the same room. So you have assessing heart strength with an echo. You have assessing heart scarring with an MRI, heart inflammation with a PET scan. So you've got the activity, the consequences mapped out, and then you have 3 clinician skills. You have the skill of how you treat the sarcoid itself. You have the skill of what medicines you use to support the strength of the heart, and you have the skill of dealing with rhythm disturbances. And to have these in the same room means that you're making the right balanced decisions. And I'm saying all this because there's a lot of this around cardiac sarcoidosis. So that has to be a major initiative. So just to summarize what is a long answer to a simple question, multi-organ sarcoidosis, you're applying exactly the same principles. You're risk stratifying. To do that, you've got to identify danger. You're better at doing it in the lungs. You're aware of the problems in the heart. Therefore, you have to go the extra mile to rule out major cardiac sarcoidosis. And doing that, I've got some extreme surprises by what can emerge when you do the tests. That you're not picking up on an ECG, you're barely getting anything on symptoms. Sometimes the echo is not telling you this. So that is major work to be undertaken over the next few years. The other organs, you're talking about very rare causes of death, and by and large, as I said before, their involvement is pretty obvious. So you're not having to go searching for hidden danger for the most part. If I was seeing a doctor about my pulmonary sarcoid, I would want to know what danger there was, and I would want to have a discussion on the pros and cons of treating for quality of life. I would also want to know the diagnosis was secure, and if it wasn't quite secure, I'd be expecting to have a discussion on what the other possibilities were, and then have a discussion on my own preferences as the patient on how far to go with diagnosis. And I would want a negotiation. And I wouldn't want the doctor telling me about how I should proceed. I would want a balanced approach, and then I might well decide in those areas, if I don't have expertise myself, that I've got to then trust the advice I've given. It's a guarded trust because you have to keep coming back as a patient and exploring what changes. So it's information, in one word. The security of the diagnosis. The other diagnostic possibilities, where if you don't make the diagnosis, things might go quite badly. So what is the risk here if the diagnosis is not immediately accurate? So if there's a negligible risk of the alternatives actually causing a problem, that's very different to lymphoma still on the table and isn't excluded. And then, given the diagnosis, what's the level of my danger? So is it actually that I'm very likely to have a normal life expectancy with the pattern of my sarcoid? Is it clear that right now I've got to take steps because there's risk? Or am I in a grey area where we might have to keep coming back and checking on the danger question? You know, sometimes these things only become apparent with a bit of time, when you look at how an illness might be behaving. So then I'm moving to feeling unwell. And I'm wanting to hear that if I'm feeling fine and I'm not in danger, I really want as a patient to be told I should not have therapy. There's no logical reason. And so it's the patient should have clarity on these points. And one of the things I really want to explore in my mission statement as now Vice-President of WASOG, and they have a cycle to elect a president, we need a patient charter where we have for patients an expectation of what they should have and what they should know. And that is the most effective way, I think, of empowering people. So in the meantime, I offer that advice. Get these questions on the table. Security of diagnosis. I'm going to say it again because it's not that complex, but it deserves repetition. Is the diagnosis secure? If it isn't, what are the alternative diagnoses? And now let's talk about whether it is worth going to a biopsy procedure and expecting my views as the patient on risk-benefit may very well swing the decision if it's a close call. They should be told that the two sources of danger tend to be the lungs and the heart, and I think that they've really got to probably say to the doctor, what is your view about the possibility of cardiac involvement, which will prompt questions about palpitation, breathlessness that might be out of keeping with the lung disease, focusing on ECG and echo. And if you have a completely clean slate on those things, I'm not sure you go to screening at that point with the advanced imaging. But it's more, I think you would want to know, as I said, the two sources of danger, and you'd want to hear the grounds for believing that those two dangers are not operating. And by doing that, I think you draw the right questions out on the possibility of cardiac involvement. I don't think I can give anything more exact from a patient point of view other than awareness of this, and then wanting to discuss their awareness of it with the doctor. It still comes back to the information, the core information. So if I was designing the patient charter now, I would be actually outlining these points, and it would be the patient right to clarity on each of these points. And on the cardiac part of it, awareness that there is a lot more of it around than people realize. It can be trivial, and that's defined using advanced imaging. Sometimes it can be watched because there's just evidence there's been a touch of activity in the past that has now gone away and left a minor footprint when it comes to looking at the imaging. But I think just the essential pieces of information and the request for clarity gives you the lead into the complexity. I wouldn't come with a list of 20 questions on cardiac sarcoid, but just to expect a dialogue on it, that's all.